Okay,
So,
so welcome back, Dr. Rudy, with us, and you wanted to talk us about iron overload. So let's go.
wow. So, Stephen, this is a topic that I stumbled into, and I'm realizing it may be the most important topic that we're not talking about. Iron overload is the 800-pound gorilla in the functional medicine room. So, what do we do in functional medicine in optimization, testosterone replacement? We want to be our best. We want to improve cellular aging, as we age to make sure that our cells remain healthy. We try to use biohacking things like nutrition, autophagy. How do we do antioxidants um, to decrease aging? How does cellular aging happen, right? When cellular respiration happens in our cells or in our mitochondria, oxygen comes in and makes ATP to provide energy, but it also creates reactive oxidation species or OS. And there's the theory of free oxidants theory of aging, that when oxygen happens during cellular respiration, it makes ATP, but it also makes oxidants or OS. And those oxidants are what ages our cells and then causes cellular senescence. Well, guess what? It's not just oxygen that causes that. Oxygen combined with iron is the most destructive radical that can affect our cells. So iron, when we think about it, iron rusts everything. Iron rusts our cells also. So we get rusting of our cells, of our mitochondria. Iron overload is one of the most important. It's actually, there's a great book by Jim Moon, PhD, Iron Toxicity. And his sentence, based on multiple studies, and I'm going to quote that: iron overload is the pathogenic event that happens with cellular aging, and it's intracellular iron mismanagement. When you have iron overload in your cells, it creates junk, it rusts, it creates something called lipofuscin that cannot be degraded, and it causes mitochondrial dysfunction. It is at the basis of almost every chronic illness that we have. And iron overload happens to everybody because iron is one of the most. First, iron has a paradox. Iron is necessary for life. It's necessary for growth of our muscles. There's something called the Popeye effect, right? That when you look at that cartoon, I don't know if you know it in Europe. Do you know Popeye? So Popeye is a
Yeah,
cartoon
yeah.
that we have. Yeah,
Spinach.
and exactly. He eats spinach to get iron, and he gets big muscle. So we all have in our mind that eat more iron to get stronger and get more muscles. It is true, but only to a certain extent. After it creates growth and then you get the iron, it's good for the short term, but in long term, that iron overload will rust our cells. And everybody will deal with iron overload at some point because every iron that we take from our diet, we cannot eliminate it. Iron is the only element that the human body doesn't have a excretory mechanism. There's no way to excrete it. There's natural losses of about 1.2 milligram of iron a day, but anything above that that you take in your diet just gets stuck in your cells and in your tissues. It's
Okay.
crazy. And in the US and also in many places in Europe, they fortified our foods with iron. They put
Mhm.
iron filings in most of our grain, the flour, also all of our pasta, bread, crackers, they're fortified with iron. So, and that was done because there still is a lot of problem with iron deficiency anemia in women of childbearing age, whether they go to pregnancy or they have heavy period and they lose iron. There's issues to say iron deficiency anemia is not really an iron issue; it's mostly a copper. So there's a lot of discussion in this, but that's why they added iron in all of our foods. So picture this: a man who does is not protected by his yearly monthly period, like a woman. Women are protected. He eats a lot of iron. He eats a lot of meat. He takes a lot of the supplements that we take, multivitamin, have extra iron. All this iron that we take, we don't excrete it. So it builds up with time. And iron overload has been associated with almost every single aging illness. It
Mm.
can cause the first place it deposits, it's in your liver. So it can cause fatty liver or any abnormality of your liver. Second, it's in the pancreas, causing diabetes or insulin resistance. There's a lot of association with high iron and insulin resistance, and the opposite also, where insulin resistance causes your body to retain more iron.
Mm.
Then it can goes into your thyroid, where it goes very easily to your pituitary. and it destroys the gonadotropes in the anterior pituitary. So you have lower LH and FSH. So one cause of secondary hypogonadism or hypogonadotrophic hypogonadism is iron overload.
Mm.
So if you take too much iron, or if you have a genetic condition to retain iron, like hemochromatosis, you have iron overload. The pituitary is extremely sensitive to iron overload. And they've done studies in autopsy where they see that even in the general population, starting at the age of 30, you already have infiltration of iron in your pituitary. And you get so a lot of patients who come in with low testosterone and a low or normal LH, that's secondary hypogonadism, think about iron overload. That's actually a pretty common cause. And I discovered all this recently. Um, Hemochromatosis, which is a genetic condition where your body takes in, you cannot get rid of the extra iron stored. So what hemochromatosis is, it's it prevents your iron, you keep absorbing iron despite normal or elevated iron stores. So it's almost like a thermostat that although it's cold, it keeps on. So the switch stays on. And it's associated with secondary hypogonadism. Another cause, another symptom of iron overload is chronic fatigue, erectile dysfunction. Iron was found to be directly toxic to the penile tissue. So people with iron overload, they'll have ED, even sometimes without. So all of the symptoms. So besides liver, pancreas, pituitary, it's been associated, iron overload has been associated with multiple neurodegenerative diseases like Parkinson's disease, multiple sclerosis, Alzheimer's dementia. It's been associated with multiple cancers. Iron is a cancer causing agent, whether it increases risk of colorectal cancer and multiple cancers. Arthritis, so iron can deposit in the joints. So one complaint of many people with iron overload is joint pains, gray hair, wrinkles, age-related macular degeneration, deposits in the eye, arthritis, kidney disease, hypertension. So almost any chronic illness that we get with aging, you can trace it back to iron.
Mm.
So cellular iron mismanagement, to me, is the most important biohack a biohacker or somebody who's trying to optimize needs to know.
Mhm.
It's crazy to me that we see that we've talked about all the biohacking secrets like nutrition, sleep, exercise, supplements, even genomics, but we don't talk about iron overload. Iron overload, to me, not just to me, the studies are very strong that it is one of the most important determinants of aging. There's a study, and that's fascinating, a study that was called the Copenhagen Heart Study, where they looked at people in Finland, and I think they took out about 8,000 men over 20 years. And they looked at it, almost the Framingham Heart Study of the US. And they were able to trace their ferritin levels to longevity. And they
Mm.
saw that guys who had ferritin above 600, most of them died in their mid 50s,
Mm.
from 400 to 600 in their 60s, and the goal was below 200. Guys who had their ferritin below 200, their average life expectancy was 72 versus 56 or 54 if you had above 600. Direct linear correlation. No other blood test has been shown to have such a direct linear correlation with longevity. Not
Mm.
cholesterol, not blood pressure, nothing. Ferritin.
Yes.
So it's crazy for me that, and even me, I've been doing age management medicine for 15 years, never paid attention to iron.
Mm.
And the way you deal with iron overload is by blood donation. And when you think about this, in our medical history, we've used bloodletting for hundreds, if not thousands of years. Medieval doctors used to do bloodletting, venesection, leeches. They were saying we're getting rid of the bad blood. It's the iron, the extra iron that you're getting rid of.
Yes.
So most good longevity protocols that you're getting out there, you're seeing that blood donation is part of their protocol. Now I finally understand why. It's the
Mm.
ferritin. And ferritin is a tricky blood test because it is what we call an acute phase reactant. Ferritin can go up for other reasons than iron overload. It can
Mhm.
go up in insulin resistance, diabetes, increased visceral fat, obesity. It increases in infection. So chronic, if you have an autoimmune disorder, I've seen patients with lupus or rheumatoid arthritis that their ferritin was in the 800 range and their iron overall was low.
Mm-hmm.
But the study, the Copenhagen heart study, did not even determine what caused your ferritin. Because if you have a high ferritin from a chronic inflammation or chronic autoimmune disease, you're still going to have a shortened lifespan. So ferritin has been something that I check on every patient because
Mm-hmm.
it really says it either implies that you have iron overload, or if it's not, it implies that you have something going on, either an autoimmune or inflammation. We need to find out why. So I check ferritin on all of my patients now. And the ferritin range is so wide, just like our testosterone range.
Yeah.
For men, normal ferritin is 30 to 400. That's a crazy range, right?
Mm-hmm.
So you 399, you normal, you 31, you normal. That's not it. So if you look at the Copenhagen heart study, the goal is to get you below 200. And
Mm-hmm.
a lot of other studies have pointed that that linear relationship continues after the 200 range. So really, most functional medicine specialists will go that the optimal range of ferritin should be between 40 and 100. They
Mm-hmm.
even go between 40 and 7. How do you achieve that? Blood donation. So blood donation is something important for anybody trying to optimize and trying to do age management.
Oh.
And now let me tell you the relationship of testosterone replacement therapy with iron overload. And this blew my mind. This paper actually came out in 2018, and it's all centered on a protein called hepcidin.
Mm-hmm.
Hepcidin was only discovered recently. Let me go over iron physiology really quick. So hemochromatosis, which is the genetic predisposition to for iron overload, it's the most common genetic disease in Northern European ancestry. Northern European ancestry, it's actually called the Celtic curse. It originated around the Viking countries around Northern Europe. And at that time, if you had the gene to conserve iron, you had a biological advantage to pass on your genes, because if you're in an iron poor environment, you had that gene. Even if you don't, you conserve your iron more. But at that time, 1,000 years ago, 800 years ago, the average lifespan was 40 years old. So people never got to the point where they had to deal with iron overload. So if you have Northern European descent, it's 1 in 10 chances that you carry a gene, a SNP of hemochromatosis. Whether you're homozygous, meaning that you have the two alleles, this is about 0.5%, or you have one allele, one out of two. And it's been shown. So I've seen guys with iron overload, and I send them for their genetic testing, and I send them to the hematologist, and they'll come back with sometimes one out of two alleles for hereditary hemochromatosis. And they'll tell them, no, you don't have the disease. Don't worry about it. I disagree with that, because even if you have one allele, you have more tendency, and studies show that there's a possibility that you accumulate iron more than the general population.
Mm-hmm.
So think about this for a minute. In the US, if we do this, we have a lot of Northern European ancestry. If 10% of the Northern European descent have a gene for this, that's 35 millions in the US. In Europe, think about it. In Ireland, it was found to be 1 in 5, 20% of people carry one or two of the mutation. And if you're now exposed to a high iron environment, like the American diet is, in the UK, they fortify their foods with it also. So now you can much easily develop iron overload. And they actually found out how does hemochromatosis cause iron overload, is that it decreases that molecule, that protein called hepcidin. Iron
Mm-hmm.
physiology is very simple. If you have low iron stores, the way we get iron in our body is by diet or by recycling of our red cells. Most 90% of our iron comes from the recycling of the red cells in the spleen, from the macrophages. About 5 or 10% comes from our diet. And that's regulated by a protein called ferroportin. Ferroportin is in the enterocytes, in the intestine. So when you eat iron, it's if you have low iron stores, your ferritin portal is open, so you absorb it, and it's transported into the liver. Hepcidin, that protein, monitors that. Now, if you have a high iron store or normal iron store, you have a high level of hepcidin, and the ferroportin is closed, meaning that you cannot absorb the iron. And it makes sense. The human body makes sense, right? The human body is so physiologically perfect. If you have enough iron, you get high hepcidin, no iron absorption, no release from the macrophages. So you stay in balance. What they found out is that hemochromatosis decreases hepcidin, meaning that even though you have normal iron stores, your body keeps absorbing through ferroportin. So you have normal or high levels of iron, it should be shut down. But hemochromatosis decreases hepcidin, so your body keeps accumulating iron.
Mm.
And here's the kicker: testosterone does the same thing. Testosterone decreases hepcidin. So when
Mm.
you do therapeutic testosterone replacement therapy, you decrease your hepcidin, and the paper cited that. Testosterone causes physiologic hemochromatosis because
Mm.
it decreases hepcidin. Let me
Mm.
say that again. Testosterone causes the same defect as hereditary hemochromatosis.
Yeah.
It's called physiologic hemochromatosis. So anybody taking testosterone absorbs iron more because it suppresses their hepcidin. So I started checking iron on all of my patients when they're at diagnosis. First, I've seen a lot of patients that I can say that their LOTI, secondary hypogonadism, was possibly caused by iron overload infiltrating their pituitary.
Mm.
Number two, on my patients that been on testosterone for a long time, I see a lot of iron overload. Most of them don't have hemochromatosis. Most of them are high ferritin or high iron saturation because of the effect of testosterone hepcidin. And if you have one or two of those alleles, even more. So now testosterone, it's like a yin yang with iron. Iron overload can cause low T. You take testosterone because of low T and causes more iron overload. Iron
Mm.
overload sometimes doesn't cause any symptoms short term. It's in the long term that you see that. Or the symptoms are so non-specific. You're tired, you have erectile issues. You're like, yeah, I'm getting old. You have joint pains, you have more wrinkles. A lot of it can be iron overload.
Mm.
So I've had many discussions in the past. What do you do about guys who take testosterone and develop secondary erythrocytosis, high hemoglobin hematocrit? There's been back and forth whether blood donation is good.
Yeah.
There's no real studies long term that showed any harms for any ill effects of elevated hemoglobin hematocrit long term. There's one study that was recently done by Dr. Ramasamy at University of Miami that does point that high HNH, especially the first year after you start TRT, can be a marker for more cardiovascular disease. So that answer is not there. But what the answer is clear is that if you have high iron overload manifested by a higher than normal ferritin or iron saturation, your risk of heart disease, cancer, and chronic disease increases. It is that simple. And
Mm.
the way you measure that is the ferritin level. You need to keep your ferritin below 200 and optimally below 100. So this is what I do with my patients now. I check a ferritin. If it's elevated, I'm trying to see, okay, is it iron overload or is it insulin resistance? Is it autoimmune disease? Is it inflammation? What's causing that? But no matter what, we need to monitor that ferritin and make sure that it goes below 200 or below 100. On a
Mm.
lot of my patients, once they lose weight, the insulin resistance goes away, their diabetes gets better, the insulin goes down. It's called hyperferritinemia. There's actually a name called DIOS, dysmetabolic iron overload syndrome, that you see with metabolic syndrome with high ferritin. It may not be iron overload. So there's a lot of nuance to it. But a high ferritin to me is a bad thing no matter what, we need to bring it. And for my testosterone patients, for example, my ferritin, when I checked it, my ferritin was 285. My
Mm.
iron saturation, I've been on testosterone 6 years. My iron saturation was 49%. Normal iron saturation is up to 45% in most cases, but the new ranges are up to 55%. So anything above 45%, you want to take, oh, I may have a little too much iron. So anything above 45% or ferritin above 200 per Copenhagen study or 100 optimally, you should donate blood.
Mm.
Then I went and researched, what does blood donation do? And it's amazing the number of studies to see the benefits of regular blood donation. So they've done studies where they looked at frequent blood donors, and that's once or twice a year, versus non-donors. There was an 88% reduction in cardiovascular disease. There was a decrease in cancer, decrease in overall mortality. Then the criticism of those papers was always, donors tend to be more healthy. If you donate blood, they check your blood. If you have any issues, they won't let you donate. People who donate blood tend to have a better diet. They tend to be healthier. So there's the healthy donor bias. They've done studies where they looked at frequent blood donors versus infrequent blood donors. And they saw that the frequent blood donors have a healthier lifespan. For every blood donation, you decrease your risk of cardiovascular disease by 7.5%. The studies are out there. So, Stephen, that was mind boggling to me that you
Yeah.
see that I've been talking about age management and optimization medicine for all those years, and we're missing one of the most basic physiologic tenets of
Yeah.
cellular aging. And it's not me saying it. Anybody can go just Google iron overload. David Sinclair did an amazing talk about it. There are great books written about it. There's a book called Dumping Iron. I'm actually working on a book in an online class to teach people this because Jim Moon, PhD, said that. Is that you could be doing everything right. You eat well, you exercise, you sleep well, you take all your supplements, and all of this is for nothing because you have iron overload.
Mm.
So iron overload needs to be part, cellular iron management needs to be part of age management. We
Yeah.
need to talk about it more. We need to check levels. Most patients that I check those levels, that's the first time they check their iron. So it
Yeah.
is for patients to know it is not part of a yearly physical. It's not part of routine labs. And there's two tests I usually check for iron. Number one is the ferritin. Number two is the iron studies that include total iron, TIBC, and transferrin saturation. With
Mm.
those two, it can give you a pretty good idea of your iron stores. What's bad with this, those blood tests are not perfect. There's so much variation. I see so much variation with it. So blood iron can underestimate tissue iron, but almost 10x. You can have a lot of iron in your liver and your tissues, and your ferritin or your blood tests are not even that elevated. So for my patients who have iron overload, and I see that they have either one or the two of the hemochromatosis, we go further. We order an MRI because an MRI, so before it used to be that you had to do a liver biopsy to determine iron content. Now
Mm.
they have a new software in MRI. It's called the liver iron content. LIC. Not every MRI does it. You have to ask your radiologist, do they do it? But if you have iron overload, you should get an MRI done to look at the liver iron content because that gives you a much better idea of your total iron stores. And if you have high iron, whether it's in the liver, the heart, a lot of cases of arrhythmias, palpitations, congestive heart failure, or iron deposition. Cholesterol. When we think about cholesterol, does cholesterol cause heart disease? There's a lot of theories that make sense. It's called the iron heart hypothesis because cholesterol doesn't cause heart disease. Oxidized cholesterol causes heart disease. That's the plaque. And what is oxidized LDL? It's rusting LDL. It's iron that combines with cholesterol. Now it makes an inflammatory plaque. So without iron, cholesterol, it's not the culprit. So this is very important. There's something called the Fenton reaction. It is when during cellular respiration, oxygen makes ATP, also makes H2O2, hydrogen peroxide. If hydrogen peroxide mixes with free iron, it causes what we call the Fenton reaction or the hydroxyl radical, OH minus. This is one of the most active and damaging radicals or oxidants to nucleic acids. So it causes DNA mutation, it causes lipid membrane abnormalities, it causes protein denaturation. So it affects the cell from every level. And iron is at the base of it. So
Mm.
we need to go back to our basic physiology and understand that if we're going to do age management, we need to think about iron management.
Yeah. Well, that's all new for me as well. Yeah, that's mind blowing. So
Yeah.
yeah,
So,
to check
Stephen, I
those
invite
levels.
you
Yeah.
to check your iron labs and maybe let's do a call together to review your iron labs.
Hmm. Sure.
Everybody on testosterone should check it. Every person of Northern European descent should do their genetic testing for the HFE
Mm.
mutation to see if you have one or two of the alleles. Your ancestry is Northern European. So you have a 10% risk of having this without
Yeah.
knowing,
Yeah.
right? So they've done studies. Should there be mass screening of HFE?
Hmm.
It doesn't make sense for mass screening, but what I tell people, if you're Northern European descent, if you do your labs and you see that you have higher levels of iron, it's worth doing it. Because
Yeah.
what I like with this, you can check it very easily, and there's an easy solution. If you donate blood, you keep your levels low, you decrease your tissue iron, you have less possibility of complications. So I saw a case recently. This guy was 45, developed diabetes at 35. Also, low testosterone, came to me. He said, my diabetes sucks, no family history of diabetes, but really bad habits. He's been drinking alcohol since he was 15 years old from the UK, actually,
Mhm.
been going to the pub, drinking pints with his mates. That's part of the culture. And he did 20 years of drinking 6 to 8 pints of beer every day. And he developed diabetes at the age of 35.
Mhm.
20 years from 15 to 35, bad diabetes. Also, he complained of chronic fatigue, of fatigue that is unexplainable, low testosterone. What's the basis of all this? I checked his iron. He had a ferritin of 800, iron saturation of 58%. I checked his genetic testing. He had one out of the two. The SNP is called the C282Y genetic
Mhm.
mutation. He had one out of the two. He went to see a hematologist. The hematologist told him, "No, don't worry about it. You don't. It's a homozygous disease. You only
Yeah.
have one out of the two. You're just a carrier. Don't worry
Mhm.
about it." I said, "I disagree completely. He has one out of the two that can cause iron overload because of his poor lifestyle, the drinking. Actually, drinking alcohol also decreases hepcidin. So hepcidin is in the center of iron physiology. So things that decrease hepcidin include genetic hemochromatosis, testosterone replacement, growth hormone replacement, alcohol drinking, insulin resistance. All those things affect hepcidin. When you have a low hepcidin, your body keeps absorbing iron, even when you have normal or high stores. So it
Mhm.
stays on, you absorb it. The only way to get rid of that accumulated iron is through blood donation. Of course, what I tell patients who have iron overload, start seeing where are you getting extra iron. A lot of people will take their multivitamins, and when they look at it, it has 18 milligrams of iron. Centrum, which is one of the most common multivitamins in the US, it has 18 milligrams of iron. Because in
Mhm.
everybody's mind, iron is good for muscle, for growth, and for feeling tired, for energy, which it
Yeah.
does, but not at higher dose. So I tell everybody, go and look at your multivitamin, go and look at your protein powder, your protein bars, see if there's iron in it. If there's iron, ditch them. Men don't need more iron. Postmenopausal women usually don't need more iron. We have enough iron in our diet.
Okay.
So what I do with a person with iron overload, first, I tell them, let's decrease your dietary iron intake. It makes
Mhm.
a small difference. The most important thing is blood donation, and it
Mhm.
all depends on what your levels are at or your ferritin. You need to donate once or twice a year, 3 to 4 times a year. My patients who have ferritin of 1,000, they need to donate every 6 weeks until their iron goes down. When
Yeah.
they're too high, I send them to the hematologist. Sometimes they donate every week until their ferritin gets to a certain level, then they get into a maintenance. You need to follow the ferritin. So besides blood donation, which is the most effective way of dumping iron, you have iron chelation agents.
Mhm.
There's a natural one called IH6. It's inositol hexophosphate 6. It is a natural compound that you get from phytate, from legumes, from lentils that binds iron naturally. There's also iron chelators that are by prescription, XJade. I haven't used this. I usually let the hematologist deal with this, but that's also available. This you have to monitor it very, very carefully.
Mhm.
And the other thing, so you decrease your intake of iron, you dump iron by donating blood and taking chelators, but also you want to increase your intake of antioxidants because when you have too much iron, it oxidizes. You need antioxidants. And the antioxidants that work are things like quercetin, really important as a polyphenols to decrease the reaction, the Fenton reaction.
Mhm.
Selenium, whole full vitamin E. Vitamin E is a great antioxidant for iron. Vitamin C is a problem because when you take vitamin C with iron, it increases the absorption of iron.
Yeah.
If you have iron deficiency anemia, yeah, that's good. If you have iron overload, that's bad. And especially synthetic vitamin C, ascorbic acid, that doesn't have the polyphenols that decrease iron absorption. So my patients with iron overload, I tell them you should not take synthetic vitamin C because you're going to absorb more. So
Mhm.
whole food vitamin C that has the polyphenols, that's okay. So that's the program in trying to get your iron overload. First, I tell everybody, every man, every postmenopausal woman, and every person of Northern European ancestry should know their iron status. They should know their ferritin level. They should know their iron saturation. Then, if they have some kind of iron overload, they should know their HFE um, genetic status. Do you have one or two of the alleles? Lately there's been a lot of talk about the MTHFR SNP mutation. Really important. I actually have double copies of the MTHFR. My homocysteine level is high, so I'm taking supplements for that. But more important than MTHFR is your iron and the HFE. So a lot of people, the way you can check your HFE is in 23andMe. 23andMe, and they do the whole gene
Mm.
study. So it will be there. So that patient I told you that I found the one out of the two, I told him, did you do a 23andMe? He's like, yes. I'm like, let's check it. He had it there, but
Mm.
nobody ever reviewed it with him.
Yeah.
So if you get this, everybody in here, if you've done your 23andMe, go and look at the HFE mutation.
Mm.
If you have one out of two or two out of the two of the mutation, that's a problem.
Okay.
Iron overload doesn't cause problem in young age, except if you drink, if you have all those bad things. But most people, it's in their 50s and 60s that the iron accumulation becomes enough to cause now cellular problems, physiologic problems.
Yeah. Very interesting. I'll have those levels checked next blood exam. Yeah.
Yes, and if you want, you can do a review together. I get a lot of my patients to do the MRI with LIC, liver iron content. Some patients had to pay out of pocket, but I had a guy, his ferritin was only 400 something,
Mm.
not that bad. So I didn't expect. His liver lit up on the MRI. It's lit up. So the blood test underestimated the amount of iron he had in his lung, in his liver, and his heart.
Mm.
So if he didn't find, he was only 32 years old. If he didn't find that out, what happens is in 10, 15, 20, who knows? The iron
Yeah.
overload eventually will get him
Mm.
something.
Mm. Awesome. Thanks so much for sharing. I learned a ton, Rudy. Thanks.
Always a pleasure talking to you, Stephen.